Welcome to the Department of Medicine Grand Rounds today, May the 23rd, where we have actually a very special visitor and event, which I will leave it to Dr. Sands to introduce. I just want to say this is the second to last of our Grand Rounds for this academic year. Next week, we will not be having Grand Rounds because of the Memorial Day holiday. And so the following week, June 6th, there is Grand Round. So don't assume this is the last when there's none next week. Following will be June 6th, and it's actually another very special event, which is new in our system, and with the resident selected speaker launch for this year. And so keep an eye out for that with our special guest there. So I will leave it there and turn it over to you, Dr. Sands.
Thank you, Dr. Armstrong. And it's my pleasure to welcome everyone to this very special Medicine Grand Rounds, where today is the day of the COCO lecture in nephrology. And our speaker, Dr. Samir Parikh, is going to both give Medicine Grand Rounds imminently, as soon as I stop tying up the computer screen, and give the COCO lecture at 5 o'clock today, which will be hybrid. And so all of you are more than welcome to zoom in to his second talk at 5 o'clock. Now, I'm told that Dr. COCO is actually sitting with the medicine residents at on the Emory campus in the conference room. So in addition to this being the COCO lecture, it's wonderful that Dr. COCO is here in person, and the opportunity for those residents in the same room to actually meet him. The COCO conference is one of the premier educational conferences that we have in internal medicine. And so for those residents who are with him, they get to meet him, see who the conference is named for. Now, to introduce our speaker, Dr. Samir Parikh, we're delighted to have him. He is Professor of Medicine and Renal Division Director at the University of Texas Southwestern. He got his undergraduate degree at Harvard College, and then did come to the South, Vanderbilt, for medical school. But I guess at least at that point, he reverted to the North, went back up to Harvard, Beth Israel Deaconess for both internal medicine residency and both a research and clinical fellowship. Now, while at Beth Israel, he was mentored by our former dean, Dr. Vikas Sukhatme. So there's a connection already between Dr. Parikh and Emory. He then joined the faculty at Harvard, based at Massachusetts General Hospital, rose through the ranks to full professor before in 2021 moving to UT Southwestern as Renal Division Director. Now, for those with gray hair like me, you may remember that Dr. COCO was Renal Division Director at UT Southwestern before coming to Emory as Chair of Medicine. So there was a second connection. And then Dr. Parikh and our current EVP for Health Affairs, Dr. Thadani, had many interactions while at Beth Israel Deaconess. So as it turns out, the connections are immense. Dr. Parikh is a member of the American Society of Clinical Investigation. He has been on the ASM program committee. He's extremely well funded, has many top-notch publications, and is a deputy editor of Kidney 360. And before I use up your entire hour, Samir, I think I will pause there and turn the computer screen over to you. We're delighted to have you and look forward both to your Medicine Grand Rounds and the COCO lecture at 5 o'clock later today.
Jeff, thank you so much for the invitation. And that really, wow, I wish I could record it and have my kids listen to it. That was a very generous introduction. Let me make sure that all of this is transmitting okay. And I'll look for a verbal confirmation because I can't see people right now. So if someone could just let me know.
It looks good.
All right. Well, I will launch in. And again, thank you to Dr. Armstrong as well for the chance to present during Medical Grand Rounds. This is my first visit to Emory, and Dr. Sands offered the opportunity to do it virtually, but I just had to take up the chance to come to Atlanta This is a beautiful institution, a storied institution. I don't have to tell this audience, and I'm grateful for the opportunity to be here. These are my disclosures. None of them is particularly relevant to this talk, but I put it up just for completeness sake. And I'll start at the end by acknowledging the many people who've contributed to the story that I'll try to lay out over the next 45 minutes or so and leave time for questions. And I'll highlight some of these individuals as I move through the slides. So let me also just start off by thanking Dr. Coco for a wonderful breakfast this morning. I think Dr. Coco could hold court all day if given the chance to do so. This is an individual who, my goodness, just to give the House officers a frame of reference, I've put here on the bottom right 30 articles in the Journal of Clinical Investigation, a really robust academic, research-oriented career might include 5 articles in this journal. And so this morning I had the chance to be with a 6X professor in Dr. Coco. And so, you know, this is an enormous honor to be recognized in the legacy of Dr. Coco, as Dr. Sands mentioned, a UT Southwestern Emory connection being re-strengthened today. And so that's a privilege as well. I'll have more to say about Dr. Coco at the 5 p.m. talk. So here's the outline. I want to get this crowd excited about a diagnosis that you probably feel like is a dime a dozen. Part of the reason I think acute kidney injury is exciting is that it's a dime a dozen. And so the opportunity to make a difference is that important as well. And what I hope to convince you of by the end of this talk is that acute kidney injury is really a metabolic phenomenon. And it can be measured with metabolic tools and maybe even approached through the lens of metabolism. And so if I get there, fantastic. And if I don't, come at 5 p.m. and I'll take a second run at it. Okay, so why should we care about acute kidney injury? Well, first off, super common, as we were just talking about. 1 out of 5 adult hospitalizations in the United States. And we have some definitions of acute kidney injury. These are for research purposes, but thinking about acute kidney injury as something that happens in the course of about a week. And then some individuals transition to chronic kidney disease. And then there's this thing in the middle called acute kidney disease. And so these are useful kind of epidemiological definitions, and we'll come back to them as I move forward. But the other reason that it's interesting to me, in addition to the huge clinical footprint and the fact that we are writing the same consult note for AKI that I wrote as a fellow, you know, close to 20 years ago, and that probably my instructors, when they were fellows, were writing as well, meaning that we haven't made a lot of progress for this very prevalent phenomenon. So that's the clinical side of why I find it interesting. I think on the basic science side, these are some of the bullets that I think about, that maybe I think about it a little bit differently than at least our House officers in Dallas think about it. The number one, the typical locus for acute kidney injury, the cellular locus, is the highly metabolically active renal tubule. And as I'll show you in later slides, there's really a mismatch between the degree of cell death and the amount of organ dysfunction, which is to say that when there's AKI, we assume that there's 0 organ function, or at least 0 GFR. But it's not like 100% of cells are dead to account for that. And so what is that mismatch? And we'll get into that. And then I think the last thing is that the kidney does have some regenerative capacity, but not a lot. It's not like Prometheus and the liver, or like the skin, or like the GI tract that's constantly regenerating through a lifetime. And so how is it that this organ can deal with a lifetime of insults without losing so much function that we all wind up needing dialysis? So these are some of the questions, you know, that I began thinking about as a fellow. All right. And so the history of acute kidney injury, this is kind of fun. And maybe for those of you who are gathered in rooms, I'll draw your attention to this here on this flow chart. So Galen was the physician to Marcus Aurelius in the original Roman Empire. And his workup for acute kidney injury was not that dissimilar from how many of us are taught AKI, right? Pre, intra, post. And this is largely a post-renal workup. And I put this up partly for the historical interest that people have been thinking about kidney failure for centuries, but partly for this right here, turn the patient upside down as part of the diagnostic workup and then shake them around and see what happens. So that's going back, close to 2,000 years ago. In the more recent history, AKI has been written about over the last 2+ centuries with a lot of different terms. And this is a little bit like the various hands in the dark trying to grasp the elephant, and some grasping the tusk and some the snout and the skin and all that. And they're all describing different features of this very common clinical entity. Look, for example, at war nephritis, described by a pathologist and physician during World War I, soldiers affected in Germany by a nephritic syndrome, a syndrome where the kidneys weren't working, and he named it war nephritis. In World War II, physicians who are familiar to all nephrologists, Bywaters and Beale, described during the London Blitzkrieg a crush syndrome, which now we understand to be rhabdomyolysis-associated acute kidney injury. And then Homer Smith. Homer Smith is the renal physiologist par excellence. Dr. Sands won the premier award at the American Society of Nephrology Lifetime Achievement Award, named in Homer Smith's honor. Dr. Smith himself was the editor of an entire JCI issue dedicated to acute renal failure. And so many different names, lots of history has touched this entity of AKI. Richard Bright Bright's disease was likely glomerulonephritis, likely post-infectious GN, which is in our workup of AKI, but not really what I'm going to talk about. What I'm going to talk about is the more kind of garden variety, what we might call colloquially ATN, or acute tubular necrosis. And to give you a sense of, how little has changed in this field, this is the description from an American pathologist more than 120 years ago on the cellular biology of acute kidney injury. Describes a process that unfolds in the renal epithelium. So this is the tubule, swelling of cells, granules of fat accumulating in these cells. And so I'll talk a little bit more about the fat and what that might mean. And then where in the nephron this is happening. This is in the cortical part of the nephron and the convoluted tubules in that most proximal region of the nephron. And so on a global scale, right, we talked about in North America, 1 in 5 adult hospitalized patients. The numbers are fairly similar, the proportions for pediatric patients as well. And this is a survey conducted, on multiple continents, describing the rate of AKI among hospitalized patients, leading to a global estimate of millions of people, 13 million people diagnosed every year with acute kidney injury. That is, in all likelihood, an underestimate. For example, I'll point out this number in South Asia of 7.5%. In speaking with physicians at large hospitals in India, they tell me that the rates of AKI are closer to 40 or 50% in these hospitals that have 1,200 or 1,600 beds. And so this is just likely, some of these numbers are likely underreported, but massive impact of acute kidney injury. And like we talked about up front, our approach is largely supportive in 2023 and largely reactive. We are waiting for the event to unfold and then providing supportive care after it unfolds. I think, one of the other reasons to be really interested in acute kidney injury is that it flows right into chronic kidney disease, right? And so I haven't seen any great epidemiology studies yet on this question, but I'll talk a little bit about the wave of COVID-related acute kidney injury. And then, a hypothesis that many of us were discussing in 2020, 2021 is, what would this look like in terms of a wave of individuals winding up with chronic kidney disease, AKI that doesn't recover, for example. And so there are other connections as well, and I just want to run through those briefly. AKI that doesn't fully repair, resolve as the first one. But what about CKD, flipping it around as an acute kidney injury risk factor? And these are complicated graphs, so hopefully you can see my pointer and I can try to unpack this. Together, these two graphs summarize data from about 1 million patients. On the left-hand side are epidemiological data from the general population. And on the right-hand side are data from 173,000 individuals who are considered high risk for acute kidney injury. And what these investigators, this is a group led by Andy Levy at Tufts, what these investigators were looking at were two things really. One, what is the quantitative association of chronic kidney disease with the risk for AKI? Meaning, if you walk into the hospital with a GFR of 75, what's your risk for AKI during that hospitalization? Versus if you walk in with a GFR of 45, what's your risk for AKI? And so that's what the lines mean, is this quantitative association, increased hazard ratio for developing acute kidney injury as a function of the degree of CKD. And then the different lines here indicate proteinuria. So proteinuria being an independent risk factor, and again, a dose proportional relationship. So if you look at the color coding on the right, macroalbuminuric patients, higher risk at all levels of GFR, fourfold, as you can appreciate here, compared to the normal albuminuric patients, those who are not putting out a significant amount of albumin in their urine. And then you see microalbuminuric patients with intermediate risk, again, at all GFR levels. And you can appreciate how in a high-risk population, the y-axis and how rapidly that risk is coming up as well. So both general population as well as high-risk cohorts demonstrate a quantitative association of AKI with the degree of CKD. When you look at outcomes of AKI, particularly dialysis requiring AKI, this is a study of 500,000 patients at Kaiser Permanente in California and the Pacific Northwest. And just following the patient journey is really, to me, I think, very eye-opening numbers. Once a patient requires dialysis due to their acute kidney injury, their risk of dying, over 40%. If they make it to 30 days, so that's the other part of that, the slightly over 50%, most of those individuals will come off of dialysis. But some of them will have a persistent need for dialysis, which we call end-stage kidney disease. And if you step back and say, well, of these individuals who came off dialysis, that sounds really promising. The vast majority of these people wind up with residual impairment of their kidney function. And so these authors describe that an episode of dialysis requiring AKI confers a 28-fold increased risk of very bad chronic kidney disease. And this is a graph that, again, for many nephrologists, it's sort of filed away into our memory. And what it illustrates is a comparison, is a case control study out of Ontario, Canada, led by Ron Wald, that if you compare individuals who have acute kidney injury and dialysis against matched individuals who had similar degrees of illness, similar comorbidities, but did not develop acute kidney injury requiring dialysis, their cumulative risk of chronic kidney disease, these curves never become parallel. And it raises the question of, is acute kidney injury an event that sets that organ onto a pathological path? And I would argue that these kinds of data are very strong epidemiological evidence that that is indeed the case, that AKI is not just a failed stress test, if you will, for a substrate, a kidney, a host that winds up not being able to tolerate stress because of some subclinical disease. It is likely also an event that puts the kidney on a trajectory towards poor health. These are data sort of looking at this now at the level of meta-analysis, and you can appreciate quantitative associations with the risk for chronic kidney disease, end-stage kidney disease, and mortality. So AKI is a really serious event. And I would say even the kind of AKI that's the sort of 0.3 change, 0.3 milligrams per deciliter change in serum creatinine, that number of 0.3 actually comes from large epidemiological studies that have asked, what's the minimal change in serum creatinine that's needed to see a significant, measurable, independent difference in hard outcomes of hospitalizations, hard outcomes like these, CKD, SKD, mortality. And 0.3 turns out to be a significant driver of that risk. That's where that number comes from. So it's not just 0.3 is not a definition of AKI. That's just meant to sort of facilitate more billing of AKI, for example. That's a question that I get a lot. Okay, the other thing I wanted to just briefly introduce, and I'm sorry I don't have a more elegant term for this, but I'm calling this AKI eventlets that wind up going undetected. And so think about kidney function deteriorating from the peak of kidney function, which we think in humans is around age 30. And in normal health, that decline of kidney function on average, although there's wide variation, is thought to be 1 ml per minute per year. And what this graph is illustrating is that individuals with diabetic kidney disease before the advent of SGLT2 inhibitors had a much more rapid rate of decline, close to 5 mLs per minute per year. And that with this class of drugs has now become closer to 1.5 mLs per minute per year, which in the end winds up resulting in a big difference at the level of the patient, 15 years of being able to stave off the need for dialysis or kidney transplant. And so I put these curves up to maybe consider thinking about them in a quantized fashion so that it's not a smooth decline, but instead, what if it's a stepwise decline? And what if, as you sort of explode those steps, it turns out that there are all these little events that are unfolding, particularly in at-risk individuals, that wind up cumulatively looking like a smooth decline in kidney function. And we currently lack the tools to test this hypothesis, right? To be out there in the community and look for, how does a bout of influenza durably change kidney function, or overdosing of an ACE inhibitor durably change kidney function, or kidney structure, or kidney molecular signaling, or what have you. But there are probably some types of patients where this kind of quantized step down in kidney function is maybe more easily measured. Heart failure would be one of those, right? Constantly adjusting diuretics, constantly having hypoperfusion of the kidney. Chronic tubular interstitial nephritis, as unfolds in tropical and subtropical regions, might be another situation where there are these little heat stroke events that are slowly pushing the kidney towards CKD and towards end-stage kidney disease. And we just don't measure that right now. That's not part of how we think about the links between acute kidney injury and chronic kidney disease. And then finally, just thinking about the epidemiology again on a global scale. In high-income countries like the United States, like Canada, top 10 cause of death, kidney diseases are. And in middle and lower income countries, there are epidemics of this chronic tubular interstitial nephritis, the impacts of which, again, without really strong epidemiology in many of these countries, hard to get a complete handle on, but clearly a worldwide killer when you step back and look at this. Okay, so I want to talk a little bit about, well, what goes well when it comes to kidney health across this lifespan. I've just told you all the reasons why having kidney failure is a bad thing and how prevalent it is, but what's normally going well? And I remember in our college biology class learning this statement, ontogeny recapitulates phylogeny. And a lot to unpack there, but what I would say, when I started learning renal physiology, it's really environment drives ontogeny, drives phylogeny. And what I mean by that is that, when you think about very simply, what's the excretory task of different organisms? And you think about a seawater organism like the shark. This is the shark's excretory organ under transmission EM. It's the rectal gland. And the main job that the shark has is to get rid of or to avoid sodium intoxication because it's living in this seawater environment. And so it has these occasional cells that face into the lumen that will pump sodium and concentrate sodium twofold into the rectal gland of the shark. When you think about the kidney in humans and mammals, it's the reverse when it comes to sodium. Our job, or the tubule's job in the kidney, is to deal with the bulk filtrate that arises from the glomerulus through the hydraulic force of the heart and say, look, I need to reclaim 99-point-something% of the sodium that's been lost in that bulk filtrate. And in order to do that, the cell body is just loaded with these mitochondria that provide the energy to drive the sodium transport against a gradient. And so a fancy way of, or a less fancy way of saying that is that this is chemical work that's happening on the right-hand side here. And 2/3 of that chemical work is happening in the proximal tubule. This is some of the work that Dr. Coco was instrumental. This is how he got to 30 JCI articles, was thinking about how solutes need to be transported to maintain the interior milieu of the body, to keep the plasma very homeostatic. And so just to schematize that a little bit, seawater organisms occasionally pumping sodium out have a handful of cells that rely on mitochondrially generated energy to do so. Terrestrial organisms are having to reclaim sodium out of the bulk filtrate and do it very avidly, and so have many cells that have a high abundance of mitochondria to provide that energy to do that chemical work. And this is what it looks like again on electron microscopy. The microvilli in the proximal tubule, so we're looking at the lumen right here on the left-hand side. These microvilli expand the surface area for all of that resorption by a factor of 10 to the 3, okay? And then to power that, you know, underneath the shag carpet, these cell bodies are basically full of mitochondria to generate the necessary ATP. And so to come back to this point I set up at the beginning, AKI is really different from other kinds of acute organ dysfunction syndromes that we see in the hospital, right? It's different from myocardial infarction. It's different from stroke, even though all three of these are very metabolically active organs, in that we do not see a lot of cell death in AKI. When we see a lot of cell death, for example, in a renal infarct, you actually don't get any renal functional impairment, right? And so there's a real uncoupling here of the degree of organ dysfunction relative to the degree of cell death, meaning that there's very little cell death, even though cell death is what we're looking for when we look at a urinary sediment. We're looking for those sloughed epithelial cells turning into granular casts and whatnot. But there's very little actual cell death in the kidney compared to this 100% shutdown of kidney function. So what is that? What is that mismatch? And here I have to give credit to Dr. Sukatme, who really gave me my start in research. I was a renal fellow. He took me on in his laboratory. I had very little basic science background, and you know, really imparted a love of asking questions. We would talk in his office for hours at a time at that point. And you know, this was one of the questions that came up. What accounts for this mismatch? And so as we dug into experimental models, and this was the first paper of any significance that came out of my lab more than a decade ago, and Vikas generously, you know, asked for his name not to be included here, although, you know, I have to give him credit for spurring this kind of thinking, was that we could see this mismatch in experimental organisms. Marked ischemia in the kidneys in a model of sepsis. But what's shown here on the right is MRI imaging to look for hypoxia in those kidneys, right? So if you have ischemia, you should have hypoxia too. Turns out there's no hypoxia. The blue kidney is what a hypoxic kidney looks like, by the way, in this kind of MRI imaging. It's bold MRI. And so what is that? How could you have really decreased blood flow, but no severe tissue hypoxia? And what we speculated was that this might be a tubular cell or a set of tubular cells that are in a kind of state of metabolic hibernation. They're alive, but they're just not consuming oxygen at their normal rates. And to schematize that, this is what we were sort of thinking, that a mitochondria goes from being healthy to being unhealthy, something we could see both structurally as well as functionally, and that stops absorbing sodium very avidly. And, you know, this is sort of a mental construct I've had since I was a fellow. I don't know that anyone has ever measured a single nephron FeNA, but we all measure FeNAs for our AKI patients. And when I think about the early response to ischemia, I think about a distribution of nephrons, some of which are already becoming less avid for sodium. They're the ones giving up the ghost, if you will, and many of which are still avid for sodium. And what we wind up measuring when we measure a FeNA is kind of the integration of all of these individual nephrons, some of which are avid, some of which are not, and the ones that are not avid, a subset of those showing up as dying cells in the sediment that we can quantify. And then, you know, well, what does the renal consultant do? We're trying to get there in enough time and to weigh the age and comorbidities and to limit the concomitant noxious stimuli so that this shift doesn't happen, right? A shift towards more of those nephrons giving up the ghost, the average FeNA becoming greater than 1%. And this variance is where I've spent a lot of, the time in the laboratory kind of thinking about. And again, this is not scientific. This is just the way I think about acute kidney injury. But if you'll humor me, and if you think that this is not a totally unreasonable way to, for example, try to square how can you see dead cells in the urine at the same time that the FeNA is less than 1%, I'd make a prediction that as we think about, for example, situations like hepatorenal syndrome, where we now have an FDA-approved therapy, it might very well be the individuals who have a very low FeNA who might be the ones who have the most differential benefit from this kind of drug. Because I would argue that the very low FeNA actually indicates a very intact metabolic health of the renal tubule. And so those might be the patients whose nephrons can be resuscitated with better perfusion, for example. And so I'd be remiss if I was talking about sodium and acute kidney injury if I didn't mention this paper called Acute Renal Success. Play on words, instead of acute renal failure, acute renal success. And what Thoreau and Boylan argued was that this inability to retain sodium during AKI by these proximal tubule cells that are meant to reabsorb 2/3 of the filtered sodium in normal health, there may be one adaptive benefit to it, which is that downstream it may signal vasoconstriction through the macula densa to the glomerulus, and thereby, this was just a purely theoretical paper, but thereby prevent the host that has acute kidney injury from just urinating out their entire blood volume by having a GFR that's not matched by tubular resorption. And so arguing that there might be some adaptive benefit to quote unquote wasting the sodium, or at least having it go farther downstream where it could stimulate afferent vasoconstriction into the glomerulus. Okay, so with that sort of background then, in terms of thinking about evolution and thinking about how the environment has really impacted what do cells need to do, what do models and human genetics tell us in this space? And first off, a question that comes up is, we have GWAS, genome-wide association studies, for many, many diseases at this point, but no real good GWAS that identifies genetic risk factors for acute kidney injury. And I would argue that one, it may be that we just need to have bigger and bigger studies. Instead of thousands of patients, we need to look at tens of thousands or hundreds of thousands. But two, it might turn out that, a genetics of AKI doesn't exist yet, because it's really the insult, the severity of the insult, that drives the response. And if we do want to look for genetics underlying all of this, a reasonable place to look might be sodium wasting. But those situations turn out to be really rare. And I put 3 of them right down here: Gittleman's, Barter's, and 21-hydroxylase deficiency. These are really rare. And you can understand, if you're thinking in this evolutionary context, why it would be so disadvantageous to have sodium wasting, particularly in a low sodium environment, particularly in an environment where volume depletion, through GI losses, through hemorrhage, might be real problems to overall health. These kinds of situations will be selected against, right? And so that their population prevalence is so low is maybe not a surprise. But it turns out that when you look at these rare syndromes, monogenic diseases that affect the mitochondria, there's a very high penetrance of tubulopathy. Tubulopathy is basically tubular cells malfunctioning, but on a longer time scale than acute kidney injury. But they're doing some of the same things: wasting sodium, wasting things that are reabsorbed pairwise with sodium. And so this data suggests that in humans, mitochondrial problems are sufficient to beget tubular problems. And then the question becomes, well, then if you've got tubular problems, how do you bring the tubule back to its normal healthy state? Acquired mitochondrial diseases also suggest this kind of elision or blurring of the boundaries between acute kidney injury and tubulopathy, at least for me. So drugs that we think of causing acute kidney injury, like aminoglycosides or nucleoside reverse transcriptase inhibitors, or the very first diuretics that we wound up using, these all turn out to be mitochondrial poisons. And that's been demonstrated both structurally as well as functionally. And I've included a couple of references at the bottom here. When we look at humans, who are exposed to temporary renal ischemia. So this is urological surgery where they clamp the renal artery so that they can have a bloodless field as they carve out the cancer, but leave the rest of the kidney behind. Even in these situations, when you go back and look at human kidneys with controlled ischemia, you see mitochondria that are swollen. This is not the normal look of mitochondria. They don't look like, they normally look like sausages with those cristae very tightly packed, not like rounded up balls. And this, by the way, is the same ultrastructural appearance as what you wind up seeing in murine models, rat models, primate models, so on and so forth. And so, hopefully at this point, if you're not buying the idea that AKI could be a mitochondrial disease, you're at least open to the possibility. I'll share a little bit of experimental data, and this is a prelude really to getting to clinical studies that I'd like to share with you towards the end. In the laboratory setting, you can actually ask this question of, is AKI mitochondrial disease? You could do that by knocking out mitochondrial genes, and you can do that by putting back those mitochondrial genes. And this happens to be one of those genes. We don't need to get into the details of what this PGC1 alpha does, but suffice it to say, when we modeled a knockout situation with different kinds of insults, in each of those situations, serum creatinine here measured on the left, these knockout mice that had unhealthy mitochondria or fewer mitochondria or something going on with their metabolism that was adverse, they were susceptible. These knockout mice were acting like our elderly patients or our diabetic patients or our CKD patients, more susceptible to these insults than their wild type litter mates. And when we flipped that around and said, well, look, now we'll fortify mitochondria genetically. Again, you can't do this in people, but you can do it in animals. We saw just the opposite. These animals in the blue were acting just like young people do, or people who don't have chronic comorbidities. They were resilient against all these unrelated classes of stressor. And so that got us really interested. This concordant data set made us think we've got to dig deeper and understand what is it about PGC1 alpha, what is it about mitochondria in general that may be important. And so one of the studies we did is called metabolomics, where we just take the kidneys and grind them up and shoot them through a mass spec and look at hundreds of small molecules all at the same time. And what we found was that these vulnerable kidneys, the kidneys that were acting like our frail elderly patients, had a metabolic look in their kidney tissue that looked just like AKI. And this was, these knockout mice were in the absence of AKI. We were just looking at baseline. They had less ATP and they had more fat in their kidneys. Remember, that pathologist from the 1800s was seeing fat in those AKI kidneys. We were seeing fat in these knockout kidneys just at baseline. And these protected kidneys, the kidneys that were acting like young or resilient kidneys, had the opposite profile. Less fat, more ATP to do the chemical work, and more of this thing in the middle, NAD. And I'll talk more about NAD this afternoon, but for now, you can think of it as a kind of catalyst that enables fuel substrates like fatty acids, which is the chief fuel in the renal cortex, to be turned into ATP. And so the less NAD there is, the less conversion of fatty acids to ATP. So the kidney, the proximal tubule, consumes a lot of fatty acids to make a lot of ATP to move a lot of sodium back into the body. That's happening in normal health all the time. And what we saw when we did another round of studies in all of these kidneys, this is now called RNA sequencing, where instead of measuring small molecules, we're measuring all of the mRNA transcripts all at the same time. We saw that an entire pathway for how cells make NAD, from the dietary amino acid tryptophan, the essential amino acid, that whole pathway was being downregulated in acute kidney injury in these highly susceptible kidneys, and it was being upregulated in a coordinated fashion in these really resilient kidneys. And so that totally opened up, hey, this might be a new pathway to think about resilience of the kidney against common stressors, or what is it that differentiates young kidneys from frail kidneys. We did a couple of evaluations, and in the interest of time, looked at 2 models of acute kidney injury, in both of which we observed that there was a problem in making NAD from tryptophan here on the left, so-called de novo. And so we said, well, look, if the problem is here, that the cell lacks the enzymatic machinery to make NAD from the left, could we sneak in from the right and give NAM, which is vitamin B3 or nicotinamide? And sure enough, we were able to boost NAD levels in kidneys by giving NAM, systemically, vitamin B3, like you might buy on the counter at the pharmacy or over the counter at the pharmacy. And we were able to reset the entire course of acute kidney injury in 2 unrelated models, ischemia reperfusion and cisplatin nephrotoxicity. Over here on the left, I'm just showing more evidence that AKI and tubulopathy are very similar. This is called a volcano plot, and all the metabolites in this quadrant of a volcano plot are the metabolites that show up in excess in AKI urines. So sugars, amino acids, fatty acids, these are all things that appear in tubulopathy urines, like you might measure in a children's hospital in a pediatric nephrology practice, but they also appear in AKI urines as well. And so I think that it's been useful to think about these 2 entities as being linked. And so just to summarize those findings, one of the other metabolites we saw in AKI urines was this thing, quinolinic acid, which turns out to be an intermediate in the conversion of tryptophan to NAD. We saw this thing just spilling out into the urine instead of being converted to NAD. And then, as I mentioned, nicotinamide, a vitamin B3 based precursor to make NAD from a totally different pathway, seemed to be protective in 2 different models of AKI. And so then we wound up carrying these studies over to people. And here I have to give credit to Dr. Tadani. He generously provided insight into how to do both observational studies as well as interventional studies. And I think this manuscript in total had 5 clinical studies in it. And I won't show you all 5 of them, but what we wound up describing was that in humans at risk of acute kidney injury, a metabolic marker appears in the urine, this quinolinic acid that I was showing you on the previous slide, and evidence that giving nicotinamide to patients at risk for acute kidney injury could prevent AKI. So I'll show you that data in the next couple of slides, but just to presage it, both a potential metabolically inspired biomarker as well as a metabolically inspired therapeutic. This work was led by Ken Rauto, a fellow who's now on the faculty at UMass. And Ken said, well, look, if quinolinic acid is a very specific indicator of this NAD biosynthetic pathway, can we measure it in different populations? And so we did 2 studies, 2 patient studies, one in CABG patients, coronary artery bypass grafting patients, case control study, looking longitudinally. And he found that levels of this metabolite began rising about 2 days before a clinical diagnosis, post-op day 3 to 5, POD 3 to 5, where AKI would be diagnosed by serum creatinine criteria. And then Ken worked with colleagues at Brigham and Women's Hospital to do a different kind of study, not a longitudinal study, not a case control study, but a cohort study of all comers to the intensive care unit, about 300 plus patients, and asking what is their admission level of urinary quinolinic acid? What does that tell us about their future risk of, in this case, acute kidney injury? But we also looked at the risk of severe AKI, also the risk of dialysis requiring AKI, the risk of 30-day mortality, 1-year mortality, and there was a quantitative association. The higher the urinary quinolinic acid at the time of admission, the higher those risks were, all of those risks were for adverse outcomes. And so really encouraging that the biology we were seeing in animals was repeating in people. And this has been independently verified. Complicated slide that I won't run through, but a French group basically comparing, here's that metabolic marker, comparing it against protein-based markers that'll be familiar to the nephrologists on this call. These are so-called AKI biomarkers here, and showing favorable characteristics for the area under the curve for the ROC curve, the receiver operating curve. So they looked in CABG patients. They also looked in transplant patients, right? So I don't know at your institution what your rates of delayed graft function are, but when you take a kidney from someone who is already dead and put it into a new individual, about 30% of those kidneys won't work. That's called delayed graft function. They don't work right off the bat. And they kind of have an ischemia reperfusion injury, right? They have had little blood flow, some period of ischemia, and then they're reperfused in the new host, the recipient. And they found evidence that the enzyme responsible for chewing up this quinolinic acid became suppressed in those kidneys that developed delayed graft function. So a molecular look at how this might be happening. And I'll talk more about this again in the afternoon. Here's the interventional study. that was led by Ali Poyen-Mayer, junior faculty at Beth Israel, who's now in the Division of Research at Kaiser and has a $4 million or $5 million NHLBI R01 to do a bigger version of this study. And so in this pilot study, placebo against B3 NAM at 1 or 3 grams in a high-risk population, CABG recipient, those undergoing coronary artery bypass grafting. And the numbers of patients enrolled here, way too few for anything other than just understanding safety and dosing and pharmacokinetics, things like that. But to the extent that we could look at AKI events, that we could look at serum creatinine curves, certainly favorable, look like there was evidence of protection, just like we were seeing in those animal models I shared with you a few slides ago. We had the opportunity to repeat some of these studies when the first wave of COVID hit Boston. And so Nate Raines, who was a fellow at Beth Israel and is now on the faculty, has a Doris Duke grant to do a version of this in that chronic interstitial tubular interstitial nephritis that I was talking about early on. But his preliminary data was basically COVID AKI. And here what we did, this was a prospective pragmatic intervention that looked at patients at 2 hospitals, one hospital that had B3 on the protocol to give to individuals who developed AKI when they were admitted with COVID, and another hospital that had the same exact COVID care protocol. This was in the spring of 2020, but did not have B3 on their formula. So it's prospective intervention, it's controlled, but it is not a randomized trial. What we looked at or measured on the y-axis was the duration of survival free of the need for renal replacement therapy. So a composite endpoint of the need for RRT and death. And obviously death is a competing endpoint. Our patients are very sick. And you can appreciate that these curves began to diverge. They stayed diverged even after we adjusted for many covariates. And then in a sensitivity analysis, when we subtracted out the KDIGO stage 1 AKIs, these are the patients who just have those 0.3 to 0.5 type changes in serum creatinine, many of whom were going to get better anyhow. When we subtracted them out, if anything, the magnitude of the hazard ratio became more intense. So the sensitivity analysis, too few patients once again, but suggesting that the behavior of the relationship goes in the direction we would anticipate. And I should mention, this was not a prevention study, this was a treatment study. So these were individuals who had AKI for 2 to 3 days and had not responded to volume expansion, and they were put on a B3 protocol. And so, just to summarize all of that, quinolinic acid appearing in the urine may be a marker of this NAD biosynthesis pathway failing to make NAD and leading to mitochondrial dysfunction, which in turn leads to an inability to absorb sodium, and you wind up seeing a high FeNA clinically, whereas substituting another precursor for NAD may be potentially restoring health by restoring mitochondrial function. And so with that, let me just wrap up. In the future, we're interested in looking at the contribution of NAD, different pathways in terms of health. I think we now have a window to think about the genetics of AKI risk, but in a more specified way by maybe starting with the genetics of tubulopathy. I'll talk more about this again in the afternoon. We've reviewed a lot of cell biology, and I apologize to the clinicians for that, but hopefully we've made a connection to the protection of metabolically active organs. Some of what I've told you about B3 and NAD biosynthesis seems to be applicable in the heart, also in the liver, also in the brain. And so there are some common themes here between how metabolically active organs handle nutrients and engage in energy metabolism. We're really interested in the future of thinking about nutritional status as part of the risk factor profile. The possibilities with this quinolinic acid. Could we do real-time monitoring, like for those AKI eventlets that are happening, that we think are happening outside of the hospital? And then finally, I showed you 2 prospective interventions, one for AKI prevention, another for AKI treatment. But one could imagine a trial for established AKI and accelerating recovery. And that's a hypothesis. Again, I'll share some data this afternoon around, but we're really excited about this as well. So I'm going to stop there. A bunch of pictures, both scientific. This is my lab here from last summer. and goofing around up here, a statue of Donald Selden in the middle, a get together at our home, Halloween, World Kidney Day. It's been a tremendous ride so far in Dallas to follow in Dr. Coco's footsteps, and happy to take questions. Thank you again for the invitation. Let me see if I can stop sharing. All right.
Thank you, Dr. Parikh, for an elegant and thought-provoking talk about acute kidney injury. Really a wonderful presentation. So I have a question, which is in terms of your summary, do you think if you have patients who you think are about to go for a high-risk procedure, at high risk of developing AKI, whether it be cardiac surgery, AAA repair, whatever, can you measure that marker? Is that even clinically available? And if so, should they be treated with NAM if you have the time prior to undergoing those high-risk procedures?
It's a great question, and it's one of the things we would like to study. And so Dr. Sands is asking, could we use this metabolic marker to enrich for a population that we think is high risk? And it is, I'll share some of this data this afternoon, but individuals with diabetic kidney disease or other forms of CKD seem to have a persistent suppression in their ability to make NAD through this pathway. And so we'd love to see that study. This is a continuum of risk. And so could there be a metabolic risk factor that we unearth and try to target with nicotinamide? A very safe intervention, nicotinamide, I'll add. When we tried it in COVID patients, over 200 patients, it's a water-soluble vitamin, looked extensively for AEs, adverse events, didn't find many, as you might expect. So, and I think that's the kind of thing one needs for AKI, right? Something that's cheap, something that has a broad safety margin, especially if you're going to think about it like you proposed in a prevention setting.
Maybe to follow that, in the animal models, was it equally effective if you gave it before you induced AKI, or could you give it at a certain period after AKI? Since, as you know, most of the time we're consulted after the fact and not in anticipation.
Yeah, I buzzed through it quickly, but in the ischemia reperfusion model, we gave it basically near the peak of the quote unquote clinical injury, near the peak of the serum creatinine rise. So no pretreatment. In the cisplatin setting, we gave it concurrent with the cisplatin, figuring that nobody would be surprised if they were getting cisplatin. But I think that it is an open question, just to sort of expand that a little bit. It's an open question as to whether established AKI is kind of is there hysteresis with normal health, or is it some of the same pathways that can bring you back to normal health that kind of bring you down into the nadir of function? And so really interested in doing that. We'll share some data this afternoon on what that looks like.
Then in the chat,
yeah.
There's a question from Grady Residence, which says, if nicotinic acid B3 is effective in treating and preventing AKI, why is B3 deficiency, pellagra, not associated with AKI?
It's a great question. Tune in at 5 p.m. I think it was just missed. It's a historically interesting thing. Much of pellagra was diagnosed in the US around the turn of the century when creatinins and BUNs weren't being widely measured. And in Europe, pellagra was, 50 years before that. And so, I don't think there was as big of an awareness, but I'll share some data from published articles looking at this very question, that is pellagra a state of kidney insufficiency? And if so, what does that look like? Great question. Grady Residence, expect no less. Fantastic.
Okay, well, I guess not to be outdone. Now we have a question from the EUHM resident classroom. We are often taught FeNA as a useful way to differentiate etiologies of AKI. Yeah. How do you clinically use FeNA in your practice? prognosis.
Yeah. No, I wanted to spend a little bit of time on FeNA because, I think there's a bit of a misperception, not among the nephrologists, but, certainly when I was a house officer, our FeNAs, everyone who's on this Zoom, our FeNAs are probably 1% or less, unless you happen to go out, and have a bunch of nachos or what have, high salt intake in the last 24 hours. And what that's indicative of is this really outstanding reclamation project that had to be there from an evolutionary perspective in order to enable us to be terrestrian creatures, meaning that we are losing a lot of sodium in the all the time. And so we are, the second part of the nephron after the glomerulus really must reclaim all of that sodium, or 99 out of 100 of those sodiums. And as it's reclaiming those, there's enough of an energetically favorable gradient that a bunch of other things get reclaimed, right? Glucose gets reclaimed, amino acids get reclaimed, phosphates get reclaimed. And so this is a low FeNA to me is indicative of normal metabolic health. We measure it in patients who have an elevated serum creatinine because we're essentially asking the question, is the tubule metabolically healthy or is it not? So when that FeNA exceeds 1%, we think on aggregate, the tubules are not in a healthy state, that perhaps ischemia has persisted so long that tubule cells are starting to go into this hibernation state and from there going on to die. And so that's how I think about the FeNA. And I try to encourage our fellows to think about it as well that way. And that's why I was making that point that a really, really low FeNA might actually be a prognostic enricher for the types of patients who might maximally respond to vasoprotective therapies like terlipressin for hepatorenal syndrome.
I don't see any hand. Oh, Wendy Armstrong has a question or a comment. Wendy,
No. I was just putting, I was just actually putting the announcement for next week back in the chat. Sadly, I think we are at the top of the hour. That was really a fantastic presentation. And as a non-nephrologist in the audience, however, you broke that down beautifully and explained the science in such a way that one doesn't have to have a deep understanding of the tubule or of the laboratory to be able to follow. I particularly love it when people can communicate science in a way that engages the scientists and the clinicians, the specialists and the non-specialists in the audience. So I want to thank you so much for that.